One of the most common pills people over 60 take is now linked to memory loss and dementia. Right now, someone you love is taking a medication that a growing number of doctors say they should have stopped years ago. Not a rare drug, not an experimental treatment, a common, everyday pill sitting in a medicine cabinet right now that research has linked to falls, fractures, cognitive decline, and worse. And in most cases, nobody told them there was a safer option. This is not about being anti-medicine. Medications save lives. But after 60, your body processes drugs differently. Your kidneys slow down. Your liver clears chemicals slower. Your brain becomes more sensitive to side effects that barely registered at 50. And certain medications, widely prescribed, widely trusted, become genuinely dangerous at this age. Not because they are bad drugs, because they were never designed for an aging body on 5 other medications. I am going to walk you through 5 of them, from concerning to the one that shocks most people. For each one, what it does, why doctors prescribe it, what the research actually says about the risks after 60, and what to ask your doctor about instead. And the medication at number 1, you can buy it tonight at any grocery store without a prescription. Most people over 60 have taken it this week, and a landmark study linked regular use to a 54% higher risk of dementia. We will get there, but let's start. Number 5, proton pump inhibitors, omeprazole, Nexium, Prilosec. If you have heartburn, acid reflux, or GERD, you probably know these drugs, some of the most prescribed medications on the planet, and they work. They shut down acid production in your stomach fast. The problem is not the drug. The problem is the duration. PPs were designed for 4 to 8 weeks of use. Studies show that up to 70% of PPI prescriptions have no clear medical indication for long-term use. Yet millions of people over 60 have been on them for years, sometimes decades. Here is what long-term PPI use has been linked to in published research. Magnesium deficiency, which causes muscle cramps, irregular heartbeat, and fatigue. Vitamin B12 deficiency, a 65% increased risk after 2 or more years of use. Reduced calcium absorption, linked to increased fracture risk in elderly patients. Kidney problems, including acute kidney injury and chronic kidney disease. And Clostridium difficile infection, a dangerous gut infection that is especially deadly in older adults. PPs are on the Beers criteria, the official list of medications considered potentially inappropriate for elderly patients. Does this mean you should stop taking your PPI tomorrow? No. Stopping abruptly can cause rebound acid that feels worse than the original problem, but it means you should ask your doctor one question. Do I still need this? Or can we step down to something safer? Many patients can taper off PPs and switch to H2 blockers or lifestyle modifications, but nobody suggests it because the prescription auto-renews and nobody reviews it. But number 4 is where the list turns serious. Before I reveal number 4, 99% of viewers are still watching without subscribing. Please subscribe and like this video. My goal is to reach 10,000 by the end of this month. Number 4, statins, atorvastatin, Lipitor, Crestor. This is the one that will generate the most debate. Statins are the most prescribed drug class in the world. They lower cholesterol, they reduce heart attack risk in high-risk patients. The data for people under 65 is strong, but after that, the picture changes, and most people are never told this. For older adults who have never had a heart attack or stroke, what doctors call primary prevention, the evidence that statins extend life is surprisingly thin. Multiple reviews have found limited benefit in this age group for people without established cardiovascular disease. Meanwhile, the side effects become more significant with age, muscle pain, and weakness, reported by a substantial percentage of elderly statin users. Some studies have linked statins to cognitive issues, memory problems, confusion, brain fog, and the risk of developing type 2 diabetes increases with statin use, particularly in older adults. Now let me be very clear. If you have had a heart attack, a stroke, or you have established heart disease, statins can be life-saving. This is not about stopping them across the board. This is about one specific question. If you are over 60, have never had a cardiac event, and you are experiencing muscle pain or cognitive fog, ask your doctor whether the benefit still outweighs the risk for you personally. That conversation is not happening enough, and it should be. But number 3 is the one doctors argue about the most. Number 3, benzodiazepines, Xanax, Valium, Ativan, Klonopin. These are prescribed for anxiety, insomnia, and muscle spasms. They work fast. They calm the nervous system quickly, and for decades, they were handed out like candy. But the American Geriatric Society has been explicit. The Beers criteria, the gold standard for medication safety in the elderly, lists benzodiazepines as drugs to avoid in people 65 and older. Not 80, not 90, 65 and older. Here is why. After 60, benzodiazepines stay in your system significantly longer. Your body clears them slower. The sedation is deeper. The coordination impairment is worse. And the consequences are devastating. Falls, hip fractures. A hip fracture after 60 is not a minor injury. Research shows that roughly 1 in 3 elderly patients who suffer a hip fracture die within a year. Cognitive impairment, memory loss, confusion that gets misdiagnosed as dementia, and physical dependence that can develop in as little as 2 to 4 weeks, making these drugs extremely difficult to stop. Geriatricians have been sounding the alarm for years. Cognitive behavioral therapy for insomnia has been shown to be more effective than benzodiazepines long-term, without any of the risks. Yet the prescription pads keep moving. If you or someone you love is over 60 and taking a benzodiazepine daily, this is the most important conversation to have with the doctor, not to stop cold turkey. Never stop benzodiazepines abruptly. Withdrawal can be dangerous, but to start a supervised taper toward something safer. And number 2 is the one almost everyone takes without thinking. Number 2, over-the-counter sleep aids, the ones that contain diphenhydramine. You know them as Benadryl, Tylenol PM, Ziquil, Unisom, simply sleep. Most people think of these as harmless. It is just an allergy pill. It is just a sleep aid. You do not need a prescription. How dangerous can it be? Here is what a landmark study from the University of Washington found. Researchers tracked nearly 3,500 adults aged 65 and older for over 7 years. Those who regularly took anticholinergic drugs, including diphenhydramine, had a 54% higher risk of developing dementia compared to those who did not use them, 54%, and the risk increased with cumulative dose. The more you took and the longer you took it, the higher the risk climbed. Diphenhydramine blocks acetylcholine, the neurotransmitter your brain uses for learning and memory. At 30, your brain can compensate. At 60, it cannot. You are chemically interfering with the exact system that keeps your mind sharp. And the cruel irony, poor sleep increases dementia risk. So people take a pill to sleep that may accelerate the very condition they are trying to prevent. There are safer alternatives. Melatonin at low doses, sleep hygiene protocols, cognitive behavioral therapy for insomnia. Check your medicine cabinet tonight. If anything in there contains diphenhydramine and you are taking it regularly, bring it to your next doctor's appointment and ask for a safer option. Now, number 1, this is not a single drug. This is something far more dangerous, and almost every person over 60 is affected by it. Polypharmacy, the medical term for taking 5 or more medications at the same time. Here is the reality. The average adult over 60 takes between 5 and 9 prescription medications daily. Some take more than 12. Each one was prescribed for a reason. Each one made sense individually. But nobody is looking at what happens when all of them interact inside a 60-year-old body at the same time. Drug interactions multiply with every medication added. Taking 5 drugs means 10 potential two-way interactions. Taking 7 drugs means 21. Taking 10 means 45. And most of these interactions have never been studied together in clinical trials, because trials typically test one drug at a time in younger patients. The result: side effects that get diagnosed as new conditions. which get treated with new medications, which cause new side effects. Doctors call this the prescribing cascade. Dizziness from a blood pressure pill leads to a fall. The fall leads to pain medication. The pain medication causes constipation. The constipation leads to a laxative. The laxative causes dehydration. The dehydration causes confusion. The confusion gets diagnosed as early dementia, and nobody traces it back to the original pill. Research consistently shows that reducing unnecessary medications in elderly patients, a process called deprescribing, can improve quality of life, reduce falls, improve cognition, and in some cases reduce mortality. But deprescribing takes time. It takes a doctor who is willing to sit down and review every single medication you take, prescription and over the counter, and ask one question about each one. Does this person still need this drug at this dose at this age? That appointment rarely happens because the system is designed to add medications, not remove them. Here is what I want you to do. Put every medication you take, prescription, over the counter, supplements, everything, into a bag. Bring it to your next doctor's appointment and say these exact words. Can we review all of these together? Are there any I might not need anymore? That single conversation could be the most important medical decision you make this year. None of this is about being afraid of medicine. Medicine is extraordinary. It extends lives, it reduces suffering, but after 60, the equation changes. The same drug that helped you at 45 may be hurting you at 65, and the system that prescribed it is not always built to notice when it is time to stop. Your body changed. Your medication should change with it. And the most troubling part, nobody was in a rush to have this conversation with you because every prescription is a recurring revenue line. Every refill is automatic. Every new symptom is a new prescription opportunity. But now you know what to ask, and knowing changes the next conversation you have with your doctor. Be honest. How many of these are you taking right now, and how many of them were never reviewed again?